Okay, so back to the medulla. Spoke about the medulla and we spoke about the anatomy and the function. Remember this region right here. This was the rostral portion. In the last video, I have a picture of the rostral portion, and then we have the sensory desiccation, and we have the pyramidal desiccation. All I did was erase the sensory desiccation and the pyramidal desiccation because I want to show you the three different lesions that could occur. When you have a lesion in the medulla, most of the lesions, or most of the vertebrae that travel up, pass through certain arteries. These arteries are known as the vertebral arteries. I'm going to speak about that in 1 minute. I just want to go over something real quick. This rostral portion, right, I have it divided into two sections, a right side and a left side. We know that the right side of the body and the left side of the body are symmetrical. So whatever is on the left medulla is going to be on the right medulla. Now, if you have a lesion in one of the arteries, it's going to affect the right, middle, or lateral part of the medulla. Okay, what part? Now, it's going to affect both the rostral, the sensory desiccation, and the pyramidal desiccation, which I erased just to save space. The most medial part of the medulla, we're going to have certain arteries known as the anterior spinal artery. The middle region is going to be known as the vertebral arteries, and the most lateral region, it's going to be on this side and this side, right? Symmetrical. It's going to be known as the Pica Arteries. That's the posterior inferior cerebellar artery. Okay, where do these arteries come from and how do they get their names? Talk about it right now. Okay, so now I'm just going to draw where the arteries flow and like how the arteries innervate the three different regions of the medulla. Now, I said I'm just going to talk about the rostral portion. However, just a quick overview so you guys can understand what I'm trying to say. I'm going to draw it real quick on the bottom here. So this bottom region is going to be the spinal cord. We know that. Now, from the spinal cord, we have 4 different layers that ascend above it. We go from the spinal cord, directly over that's the medulla. Above that is the pons. Above that is what? The midbrain. Now, what was directly behind these regions, posterior to it? This was the cerebellum. We have to remember the cerebellum, we have peduncles that could go to the cerebellum as well. And that came from different regions of the what? Medulla. Okay, so let's do it real quick. Spinal cord, right? Right above that was what? The medulla. Above that was the pons, and above that was the midbrain. Now, if this is our medulla region, right, we have 3 different what? Areas. Most superior region was the pons medulla junction, and that was what? The most rostral part. Remember I said rostral and cranial is like the same name? Like, instead of using cranial for the spinal cord, they use rostral for the medulla. I didn't make it up. I don't know why. Just remember that. And what's the caudal portion? Caudal meaning the most inferior, the bottom. Okay, so that's our last layer, was the caudal. And what was the caudal layer? The pyramidal desiccation. And then the medial layer was what? Sensory desiccation. Fine. So we have our 3 different layers, right? Now, right here, this was when I showed you guys the posterior view of the medulla, and we had different things branching out. Remember the top region over here? This is the pons medulla junction. We had 3 cranial nerves, the vestibular nerve coming off of it, and then we also had the vestibular nerve and cochlear nerve, the nuclei, etc. Now, we also had, from the anterior fissures, we had the hypoglossal nerve coming off of it, okay? And then, from the longitudinal or the lateral fissures, what did we have coming off of it? Well, we had the cerebellar peduncles, right? These peduncles are what? Just white matter that different nerves could flow through in order to innervate the cerebellum, which helps us with what? Proprioception, movement, fine touch, crude touch, etc. Now, why do I have this structure in red? Like, what's this red stuff coming around it? Well, red is arteries, which we're going to talk about right now. The main, or the first artery, what are we going to have? So we're going to have 2 arteries, right, that are ascending up our body to reach what? To get to our brain. Now, we have a right side and a lateral side. Or a right side and a left side. The right side and left side ascend up together, and these guys are known as the vertebral arteries. Why do you think they're known as the vertebral arteries? Well, if I erase this structure right here, right? What comes off of this pons, off of the medulla? Well, the spinal cord. What is in front of the spinal cord, or what carries the spinal cord? Vertebrae. So these are going to be known as the vertebral artery, coming from the vertebrae. Okay, these guys are going to travel upward and they're going to meet. They're going to converge. Where are they going to converge? They're going to converge around or about the pons medulla junction in the medial location of it. So right around here. When they converge, they're going to form one artery. This artery is going to be known as the Bacillar Artery. Where is this artery located? He's in the pons. Not going to talk about the pons in this video. I'll talk about him in a later video. But just remember, this Bacillar Artery is going through the pons. As it ascends up, it's going to diverge again, and it's going to diverge into what? It's going to diverge into the posterior cerebellar arteries. These arteries are going to be located in the midbrain. We'll get to that in a later video. The most important thing I want you guys to remember is that the vertebral arteries, right, these two guys, right and left, these are going to be in the middle region of our cross-sectional view of our medulla. Now, what branches off of these arteries? Okay, so if we have two things branching off of them. If this vertebral artery, right here, this region, this is the middle. I said this is the middle section of our cross-sectional view of our medulla. A branch that branches lateral are going to be known as our Pica Arteries. Pica stands for posterior inferior cerebellar arteries. Now, he's going to be lateral. We go back to the middle region, is what? The vertebral arteries. And now if we move medially, right? A little bit more medially, we're going to have this artery right here. What is this artery known as? Well, he's the anterior spinal artery. Now, both things are going to occur on the left and the right side of the body, which we spoke about. Just the main takeaway I want you guys to know. Pica, lateral. Posterior inferior cerebellar artery, most lateral. Middle, the middle region. Vertebral arteries. And now the most medial region, the innermost, right? The most medial one is the posterior spinal artery. Now, the main takeaway is the Pica artery is going to have multiple lesions on it, or different areas of our body are going to be affected if there's a lesion or a disruption, right? If this artery is occluded, closed off. And also, there's going to be a lot of different functions that are lost if this artery, the posterior spinal artery, is occluded. What are these different functions? Okay, now we know where the arteries go and what are the three main arteries we need to focus on when we talk about the different lesions of the medulla. Now, what did I say were the three main important ones? The Pica, the vertebral, and the posterior spinal. I said Pica was the most lateral, so here it is, most lateral. Where else is he going to be? He's going to be on this side, and he's going to be right over here. I'm not crossing him out because I want you guys to just remember where all the different structures in the medulla were located. So I just crossed out one side. Now, the vertebral arteries, right, came up right from the vertebrae. Where do they branch into? Laterally Pica, medially posterior spinal artery. So they're right in the middle between these both. Now, the most medial one, I have him in red. What is he going to be? He's going to be the anterior spinal arteries. Okay, now, if you have an occlusion, right, or a lesion, they say, in one of these arteries, you're going to have different functions that are affected. I'm going to start off with the anterior spinal artery, and then I'm going to do the posterior inferior cerebellar arteries, the Pica ones. Why am I not doing the vertebral arteries? Because the vertebral arteries are going to have different functions that are lost, more down by the vertebrae region and then higher up in the pons region. For now, the two main focuses are going to be the lateral and the medial occlusions. Fine. So if we have an occlusion in the anterior spinal artery, it's going to be known as medial medullary syndrome. Okay. What is medial medullary syndrome? We're going to have a loss in a good amount of functions, but where are these functions coming from? Okay. They're going to come from three different areas on our medulla. Remember, this is the rostral portion. So we're going to have a defect in the hypoglossal nucleus. So I have number 1, right? Why do I have number 1, number 12, and number 11? Well, because in this diagram, the diagram we just spoke about in the previous video, I numbered the different structures, 1 through 35. So instead of just renumbering everything and making things all confusing, I took the same numbers from the last video, and I'm using them to explain the different structures. I'll write up like a list of the 35 structures in like the order that I posted it, and I'll put in the link below, just so you guys could like go through it, like, okay, number 1 is this, number 2 is this, etc. But let's carry on. Number 1, hypoglossal nucleus. He was located right up here. He was located where? Posteriorly and medial. So the most posterior and most medial region is going to be the hypoglossal nucleus. That's why, if you see what artery? The anterior spinal artery coming straight down in the middle. He's affecting this guy right here, number 1. He's also going to affect the medial lemniscus. Medial lemniscus was a pathway, right? It was a tract. Okay, he's going to be affected as well. What number is he? He's number 12. I had him right over here. Number 12 also connected to a couple of other structures. These structures were located in the sensory desiccation portion. And these guys were the fasciculus cutaneus, the fasciculus gracilis, the nucleus gracilis, and the nucleus cuneatus. These 4 structures help take sensory information up to the brain. Okay. Also, what other lesion is going to be affected here? What other region? I'm sorry. The corticospinal tracts. The corticospinal tracts came from where? They came from the cortex, and they descended information. They brought information down to where? To the body. What regions of the body did it come down to? Well, it came to the lumbar, thoracic, the trunks, the arms, etc. Okay, I'm not going to really talk about the different tracts because I've spoke about them a lot. I'm just going to show you briefly where these different areas are affected. So first, medial medullary syndrome, hypoglossal nucleus, the effect there. It's occurring right in this medial region, and this medial region, where is this portion? This was the posterior view. This posterior view showed something very, very, very specific. This was the pyramids. The pyramids, however, have what branched off of them? The hypoglossal nucleus. The hypoglossal nucleus is used for a couple different things. Its main purpose is known as the hypoglossal nerve, cranial nerve 12. This nerve is used for tongue movements. Okay? Now, this hypoglossal nerve, or nucleus, branches down and it travels to 2 different regions. We've spoken about the regions before, and we had the ventral, or, I'm sorry, not a ventral, an upper and a lower region. Okay? The hypoglossal nucleus, the right and the left side, gave their innervation to different functions. The right side gave his innervation into what? The right upper side, the right upper portion of the tongue, and then he gave his information to the contralateral lower portion. So ipsilateral, meaning the right upper, and then contralateral, left lower. Okay, innervation, right side, right upper. Innervation, right side, right upper to left side lower. Now, the left region of this nucleus gave its innervation where? Same thing, just reversed. So, we start off in the pyramids. We go from the hypoglossal nucleus. Hypoglossal nerve travels down, innervates the left region of the upper tongue, and then the lower region of the right tongue. Fine. If we have a lesion or an occlusion in the artery, mainly, which one? The anterior spinal artery, what's going to be affected here? Okay, the lesion is going to occur on the hypoglossal nucleus, and the main deviations we're going to see is in the genioglossus muscle. The genioglossus muscle is the muscle that supplies the lower level of the tongue, right? The tip of my tongue. Now, say we have a lesion on the left side. Okay, so the lesion is going to be right over here. If we have a lesion on the left hypoglossal nucleus, the right side of the tongue can protrude. Okay, what does that mean? So the left region, right? The lower and the upper portions are going to be fine. I mean, the left side and the right side upper regions are going to be fine. The lower portions of the left and the right side are going to be affected. Specifically, if it's on the left side, the right side is going to be affected on the lower side of the tongue. So the tongue is going to be what? He's going to be protruding left. He's going to protrude to the left side. Now, I have a video on explaining the different innervations. This is in the hypoglossal nucleus video with the different tracts, so I'm not going to go too detailed in it. I just want you guys to know the main defect is going to be ipsilateral tongue deviation, and the tongue is going to go to the ipsilateral side, so the same side. That's one main important dysfunction with medial medullary syndrome. Now, if you have a medial medullary syndrome and you affect number 12, which is the medial meniscus, what pathway is going to be affected? Well, this tract. This tract was a sensory tract. We have to remember sensory tracts travel where? From the spine upwards. This tract specifically travels upwards. Ascending is known for sensory information, and he comes from the muscle or the skin. Now, if he's coming from the upper limbs, where is he coming from? He's coming from the nucleus gracilis, right? Passing through the fasciculus nucleus. That was the most medial section. The lateral section comes from where? The fasciculus cuneatus, which travels up through the nucleus cuneatus. Good. Now, they travel through the dorsal gray horn. Dorsal gray horn is known for sensory information. Anterior gray horn is motor information. We know this. Travels through the dorsal gray horn into the dorsal white column. The dorsal white column, we know it's split in half. The medial section travels right up to this region right here. Fasciculus gracilis. Fasciculus gracilis travels up, contralaterally. So they contralaterally travel to what regions? They travel to the medial lemniscus. Same thing. Fasciculus cuneatus targets the gracilis cuneatus, the nucleus cuneatus, and they contralaterally cross and target what? The medial lemniscus. When this region is disrupted, right, or there's a lesion, where is this lesion going to be? Right around here. If you have a lesion here, you're going to see contralateral loss of proprioception, vibration, and touch. Why would there be a loss in these regions? Because this medial lemniscus, or this pathway, is known as the dorsal column medial lemniscus pathway. And this pathway was ascending information for proprioception, vibration, and touch. Now, two things that are damaged with the medullary syndrome, right? Medial medullary syndrome. You have the ipsilateral tongue deviation, and now you have contralateral loss of proprioception, vibration, and touch. One more thing occurs. Number 11, right? Corticospinal tract. If this tract, right, there's a lesion here, or you don't have blood supply, you don't have oxygen going to this region, what's going to occur? Well, we know cortico, meaning cortex, right, is taking information down through the brain. He's sending it down the spinal cord. How? Well, he comes from the cortex, he passes through, right over here, we know we have our posterior limb, we keep traveling down. What do we travel into? We finally travel into the posterior region, or the most inferior region of our medulla, which was just called the pyramids. The pyramids had a sensory desiccation. The desiccation is just a crossover. Now, we said that 85% of the fibers travel laterally, or they cross over, right, at the pyramidal desiccation, and the other 15% of the fibers cross over in the ventral white column. I'm not showing that right here, it's too detailed. I'm just going to say that at the pyramids, when they contralaterally cross over, we're going to have weakness in the opposite side. Okay, so if we have a lesion on the right side of the brain, right? We're going to travel down and we're going to have a loss of motor supply or motor function to the left side of my body. Vice versa. The lesion on the left side of my cortex travels down. I'm going to have a loss of function where? On the right side of my body. It's just contralateral. Now, we know once they reach the anterior gray horn, they release alpha and gamma motor neurons. Alpha was used for what? Motor control, like just function and stuff. And gamma is used for what? Touch. It's stretch, right? It's the length and the tension. Gamma targeted the nuclear bag fibers and the nuclear chain fibers via intrafusal fibers. The alpha targeted the extrafusal fibers. This was our motor control, like our function, our movement, contraction, lengthening, etc. Now, takeaway for the medial medullary syndrome. We're going to have hypoglossal nerve, medial lemniscus pathway, corticospinal tract. We're going to have ipsilateral tongue deviation. We're going to have contralateral loss of proprioception. And we're going to have contralateral hemiplegia or contralateral hemiparesis. Let me talk about that real quick. Contralateral hemiplegia is just going to be, it means paralysis. Paralysis where? Okay, the lesion's on the right side of my body. I'm going to have paralysis to the left motor functions or the left muscles of my body. Now, if I have a lesion on the left side of my body, hemiplegia, I'm going to have contralateral paralysis, so like I can't move my body on the right side. What about hemiparesis? Well, hemiparesis is just weakness, so that's the differences. Hemiplegia is going to talk about paralysis, so no movement at all. Hemiparesis is just going to be weakness, and we know the weakness is occurring on the contralateral side. Those are the three main important things, or the main takeaways for medial medullary syndrome. Now, I'm going to speak about the lateral medullary syndrome, the different functions, the different innervations, and what controls what. Okay, so boom, we covered the anterior spinal artery. Now, I'm not talking about vertebral arteries, we said that. We're going to speak about the posterior inferior cerebellar arteries, known as Pica. Okay, where are these guys located? So, they're in the lateral medullary, well, they create lateral medullary syndrome. And they are in the lateral side of our medulla. Okay, so, if I redraw this, right, where I redraw my spaces, if we come straight down the middle, we do a cut, this was our medial, our anterior spinal arteries in our medial side. In red, we go a little more lateral. We have the vertebral arteries. If I do the vertebral arteries, just a little cross-sectional cut, you see this is where the vertebral arteries would be. Now, most lateral side, right? It's mainly in the rostral region, it's the whole entire lateral side. However, when you go down to the sensory desiccation region, it is mainly in the posterior lateral portion. I don't have enough space to draw all that, I'll do it right here real quick. If I drew another medulla, and this is our sensory desiccation, we cut it down the middle. Medial is going to be vertebral arteries, anterior spinal arteries. In between is the vertebral arteries, so V for vertebral arteries. And now, instead of coming this whole entire lateral side, it's mainly the posterior region of the lateral side of the medulla in the sensory desiccation region. Okay, but we're not going through all that detail. We're just talking about the lateral side. Now, lateral medullary syndrome. It affects a couple different things, a lot more than the medial medullary syndrome, unfortunately, but it's not too bad. We're going to go through them quick. We'll be fine. Now, we're going to affect the medial vestibular nucleus and the inferior vestibular nucleus. Where are these guys located? Remember we have 4.1 and 4.2. Okay, right up and above each other. What were these two things? When they are combined, they form something. So if it's a vestibular nucleus, and two of them combined, they form the vestibular nuclei. Okay, that makes sense. Now, if we proceed a little bit more lateral, we had 5 and 5.1. These guys were the what? The dorsal and the ventral cochlear nucleus. Okay, or cochlear nuclei, I apologize, excuse me. Now, if they have the cochlear nucleus, if you join both of them together, what are they going to create? They're going to form the cochlear nucleus. Two of them together, nucleus. 1 and 1, nuclei. Okay, now, we have medial vestibular nucleus, inferior vestibular nucleus, dorsal cochlear nuclei, and ventral cochlear nuclei. Check. What else do we have? We have number 18 is the Nucleus Ambiguous. Where is he located? This guy, okay, in my diagram I have him dotted in as number 18 and I have him in the medial region. However, if you blow up the medulla, he's not really in this middle region. He's going to be mainly over here in the lateral side. I just didn't have space to draw him when I talked about the whole entire medulla. Okay, he's going to be affected. What does he do? The Nucleus Ambiguous diverged, right, into 3 different nerves. What were the 3 different nerves of the Nucleus Ambiguous? Well, we're going to talk about the pathway in a little bit, so I'll get back to it soon. Keep going down. We have the descending sympathetic tract. What was the descending sympathetic tract for? Okay, so if it's descending, it's going to be motor information. And if it's motor information, it's muscle movement. Now, if it's sympathetic, it's your flight or flight, running from a bear. Okay, that's number 20. Number 14 and 14.1 is going to be the spinal nucleus and the spinal tract. The spinal nucleus and the spinal tract also involve the trigeminal tract. I'm going to briefly talk about him too, so don't worry. Now, we talked about those. We talked about medial vestibular nucleus, inferior vestibular nucleus, Nucleus Ambiguous, descending sympathetic tract, spinal nucleus, spinal tract, inferior, dorsal cochlear nuclei and ventral cochlear nuclei. 2 more things we want to talk about. We're going to talk about the inferior cerebellar peduncles and the spinal meniscus. If we remember, the inferior cerebellar peduncles were the most lateral regions of what? The medulla. Remember we have 3 different peduncles. If you draw, I'm going to make a box here just to draw a quick diagram. This is the spinal cord, medulla, pons, And what's the top region? The midbrain. In the medulla, we have the inferior cerebellar peduncles. Pons, medial cerebellar peduncles. Midbrain, superior cerebellar peduncles. And all these guys are is white matter that attached from what? The medulla to the cerebellum, the pons to the cerebellum, or the midbrain to the cerebellum. We're specifically focusing on this bottom region, known as the inferior cerebellar peduncles. It makes sense for them to be the most lateral because we're exiting the medulla. Now, the last one is going to be the spinal meniscus. Spinal meniscus I have here as number 13, and he looks like he's in the vertebral artery portion. He's supposed to be located in the he's supposed to be located in the Pica region. I just didn't have enough space in the diagram to draw him. So I'm going to draw him again right here, number 13, and he's the spinal meniscus. Spinal meniscus, we have to remember, branches into 3 different regions. Now, I'm going to talk about everything right now. Just, what was the spinal meniscus's regions? Well, we had the ventral spinal thalamic tract, we had the dorsal spinal thalamic tract, and we had the tectospinal tract. Let's get to it. Okay, so let's talk about what Trusion, the Pica Arteries, so the most lateral ones in our medulla. And if you have an occlusion or a lesion in these Pica Arteries, what are the Pica Arteries known as? You know it, the posterior inferior cerebellar arteries. And that lesion or that occlusion is going to lead to what? Lateral medullary syndrome. Now, here we go. What did we say? We have vestibular, right? Something wrong with the vestibular nucleus. So the vestibular nucleus is made up of 2 different regions. It was the medial vestibular nucleus and the inferior vestibular nucleus. Okay, so I'm going to have 2 of them in this one. I have number 4. If you see the list, number 4 is going to be the vestibular nucleus. 4.1 is the medial vestibular nucleus. And then 4.2 is the inferior vestibular nucleus. But I'm just going to have both of them in this region. Or all 3 of them, we should say. Now, number 5, I have the Cochlear Nucleus. I should say nucleus because it's both of them. And you notice there's only one of them here. Why is there only one? Because 2 things make up the cochlear nucleus. What are those 2 things? We have the dorsal cochlear nuclei and the ventral cochlear nuclei. So if we have the ventral one, it's right here, and the dorsal one is going to be behind it, posterior. In the diagram, it's just going to be above. Now, I have number 5. In the list, it's going to be 5.1 and 5.2. Okay. Now, number 20, we have the descending sympathetic tract. Okay, we're going to talk about him. In this region right here, we're going to have the spinal nucleus is number 14, and then the spinal tract. What else did I mention was in this region? Well, the trigeminal tract. Well, they're all composed, and we've spoken about how they're composed, or all put together. I'll go over it again. Now, number 18, we have the Nucleus Ambiguous. We said the Nucleus Ambiguous consisted of 3 different regions or 3 different areas. Those areas were cranial nerves 9, 10, and 11. We'll go through it quick. This region, number 13, is the spinal meniscus. And then on this board over here, I'm going to show the inferior cerebellar peduncles, number 6. Okay, so these 7 regions, right, they're composed of a lot of different structures, I know. But the 7 different regions are the main regions that are affected with lateral medullary syndrome. Now, each of these regions, yes, they have similar malfunctions to our body or similar defects. However, they're all a little different in their own aspect. I'm sorry, it's unfortunate, but it's what it is. So, we'll start off. Vestibular nucleus. Okay, he's composed of what? We said it. The vestibular nuclei. Which ones? The medial vestibular nuclei and then the inferior vestibular nuclei. Okay. Where does he get his sensory innervation from? Like, where is he getting his target from? He's going to get it from the cristae and the macula. Where are these guys located? They're located in the inner ear. And they're used for equilibrium. They're not used for hearing. They're used for our equilibrium. So where our body is in space. Now, they're also going to, when they travel, they're going to travel using the vestibular nerve. Notice, I did not say anything about vestibulocochlear. So we're not worrying about the vestibulocochlear. We're only focusing on the vestibular region of that nerve. So only the vestibular branch. So they travel through the vestibular nerve and they target something. They target the vestibular nuclei. Okay, we said two things, or when things form together and converge, they form the nucleus. Now, they form the vestibular nerve, they ascend upwards, and they target something else. They target the sixth nerve nuclei. Okay, they target the sixth nerve nuclei. From the sixth nerve nuclei, I have him drawn in red right here. He could go three different ways. What are the ways he can travel? He could travel upward, so he could ascend, travel superiorly through the medial longitudinal fasciculus. I have number 17 next to him because that's where he is in our structure list. So the medial longitudinal fasciculus can ascend upwards and they contralaterally cross. That's one way. So I'll write number 1. That's a backwards one. Number 1. Number 2, it could go to the cerebellum. How will it travel through the cerebellum? Well, it's going to pass through our inferior cerebellar peduncles. Number 6 on the structure list, we spoke about it. Number 3, where can he travel? Well, he could descend downwards and follow a tract, and he could end up in the extensor muscles. Okay, so if he's an extensor muscle, he's an anti-gravity muscle. We know that. We've spoken about that. So, now, if we have a lesion, where's the lesion going to be? The lesion's going to be right where the vestibular nerve is. Okay, the lesion in the vestibular nerve is going to disrupt targeting the vestibular nucleus. If you can't target the vestibular nucleus, you can't target the sixth nerve nuclei. If you can't target that nuclei, you can't send these things in 3 different directions. These 3 different regions have their own functions. Now, if we have a lesion in this region, we're going to have certain symptoms. What are the symptoms going to be? We're going to have, it's going to be known as vertigo. That's going to be our disorder. We're going to have vertigo. And vertigo involves nausea and vomiting. So in a question or in a clinical scenario, if you see someone with nausea and vomiting, one of our things that should pop in our head is, okay, this potentially could be vertigo. Now, why do we get vertigo? Why do we have nausea and vomiting? Okay, so we have a loss of equilibrium, this means. Why would we have a loss of equilibrium? If we think about it, the 2 main regions that this tract or this lesion is affecting is our cristae and our macula of our inner ear. And these 2 structures are for equilibrium. So we're going to lose equilibrium if there's a lesion. If we lose an equilibrium, we don't have our proprioception. If we don't have proprioception, what does that mean? Example, if our eyes are closed, right, and I abduct my arm, I know where my arm is in space. If I have my arm above my head and my eyes are closed, I still know where it is. Where do I learn this from? Our proprioception. So, if this is damaged, we're going to have spinning sensations. Our body's going to be all crazy, messed up. Now, that's our main loss for this vestibular nucleus. Another side loss that can take place is diplopia. This is having double vision. So if you see like 2 different things, double vision, this is diplopia. This is not a main effect, it's a side effect, but I just figured it was nice to know. Now, the next region, the cochlear nucleus. Okay, well we just talked about vestibular. Vestibular is one part. What is cochlear? These guys usually go together, right? Vestibulocochlear. Fortunately, we broke it up, and we're going to go through the cochlear nucleus. He's going to come from the spiral organ of our corti. What is this guy? He's going to be in our inner ear, and if he's in our inner ear, he's not used for equilibrium because that was the cristae and the macula. He is used for hearing. Okay, so he is used for the ear, hearing. He connects the inner ear to the cochlear for hearing. Now, he travels up, fortunately for us, he uses the vestibulocochlear nerve, cranial nerve 8. When he travels to the vestibulocochlear nerve, he can target 2 different regions. Remember I said, it's not just the cochlear nucleus, it's 2 different parts of the cochlear nucleus. We have the dorsal cochlear nucleus and the ventral cochlear nucleus. Well, dorsal is going to be here, ventral is going to be there. In the diagram, it's below and above. In real life, it's going to be in front and behind. Or in a normal view, a 3D view, it's going to be in front and behind. Now, this vestibulocochlear nerve targets either the ventral portion or the dorsal portion. If it targets the dorsal portion, he's going to contralaterally cross over and he's going to target the lateral lemniscus. We've spoken a lot about the lateral lemniscus. I'll talk about it briefly though. Now, before I do that, if he travels up and he targets the ventral, right, the ventral cochlear nuclei, before he contralaterally crosses, he's going to target another tract, another nucleus. And that's going to be our superior olivary nucleus. Okay. When we have a lesion, right, our lesion is going to be right here in the vestibulocochlear nerve. If we have the lesion right over here, we can target the dorsal or the ventral cochlear nuclei. What are going to be our side effects? We're going to have sensory neural deafness on the opposite side. What is the opposite side? Contralateral side. So, if the vestibulocochlear nerve on the right side of our body is damaged, we're going to have a loss of hearing on the left side. And why do I say neural deafness, right? What does this mean? Well, it's coming from the cochlear, our inner ear. That's the reason why I say that. Okay, so boom. Lateral medullary syndrome. So far, we have vertigo, which is the loss of equilibrium from our inner ear. And we have a sensory neural deafness, so a loss of hearing on the contralateral side of our ear. Those are two important things that we've already discussed. Now, what else do we have? If we come from a lateral medullary syndrome, what's affected? The Pica Artery, posterior inferior cerebellar artery. We're going to affect the descending sympathetic tract. Now, the hypothalamus, we haven't spoken about him yet. However, he's in the region of our brain and he's branched into two different areas. He has a sympathetic supply and a parasympathetic supply. We're specifically talking about our sympathetic supply. Our sympathetic supply travels down our brainstem. He travels down to the spinal cord. And he's going to target specifically T1 through L2 vertebrae. Is it the vertebrae? No, it's that region. What is in that region? The T1 and L2 spinal cord. Okay, if it's targeting those regions of the spinal cord, it's going to target the muscles and locations of our body that's affected with that associated region. Now, what occurs? Okay, so the descending sympathetic tract travels out through the T1 and L2 vertebrae, and they kind of ascend and they hit something called the superior cervical ganglia. Now, this ganglia has a couple important functions. He helps to dilate the pupilla. He helps for eyelid contraction or extension, like opening and closing of the eyelids. And he also has sweat glands of our face. Okay, now, if we have a lesion in the descending sympathetic tract, right, because we don't have blood flow, so there's going to be an occlusion of blood, an occlusion of oxygen, we can't have this tract be fired properly. It's going to be defective. He's going to result in something called Horner syndrome. Okay, so remember, if we have left medullary syndrome, we're going to have something called Horner syndrome. Horner syndrome is a complication of three different things. These three different things are no eye elevation. Okay, so we can't, no eyelid elevation, I apologize. So what does that mean? The eyelids can elevate. Now, we're not going to have pupil dilation, so what's that mean? The pupils are strictly constricted, or strictly constricted. Okay, and we're also going to have no sweating. So our face isn't going to sweat. These three different categories have specific names. So the first one, no eyelid elevation is going to be known as ptosis. I know it's spelled P-T-O-S-I-S, but that's what it is, ptosis. Now, meiosis is going to be no pupil dilation, so just strictly constriction. Lastly, anhidrosis means no sweating, so no facial sweating is going to occur. These three complications are going to lead to something known as Horner syndrome. So far we have three different things for lateral medullary syndrome. We have vertigo, we have a sensory neural deafness, and we have Horner syndrome. Four more things to cover, and then we knock this thing out of the park. Okay, so for the spinal nucleus and the spinal tract, also the trigeminal tract, what occurs here? Not too bad, we spoke about him a lot, but we'll do a quick recap. We have, where does it come from? The original origin is from the trigeminal nerve. We know the trigeminal nerve, tri for three, has three different branches. V1, V2, and V3. Okay, V1 is for the oculomotor, V2 is for the maxilla, or maxillary region, and V3 is for the mandibular region. Fine. Now, fortunately, in this video we're not talking about all the different branches, but they converge together. So when they converge together, they're going to be known as the spinal tract. Okay, So right here, when they're V1, V2, and V3, they're known as the trigeminal tract. Makes sense. It's trigeminal nerve flowing different ways, trigeminal tract. However, when they converge together, we form the spinal tract. So that's the second thing I mentioned was the spinal tract. This spinal tract is now going to target different regions in our brainstem. What are these three regions? So I'm going to just draw it right here real quick, a separate region of our brainstem, just so we can get a good visual. We have the spinal cord, which we've said 100 times. Then it goes up to the medulla, then to the pons, then to the midbrain. Okay, so in the midbrain, in the medulla region, we have something called as the spinal nucleus. It's the one we're going to mainly focus on. In the middle region, or in the pons region, specifically, we have the pontine nucleus, pontine for pons. Now, in the midbrain region, we have the mesencephalic nucleus. So our spinal tract targets these three different nucleus. However, we're only specifically speaking about the spinal nucleus because this video is on lesions of the medulla, not the pons or the midbrain. Okay, so I'm going to erase this guy. I just wanted to give you guys a quick run through one more time. Okay, so I have left, right? So I couldn't draw it in 3D. Just know we have two. One on the right side of the body and one on the left side of the body. This one's going to be on the left side, so he's going to be over here. Now, he's located right in the medulla region, and he's getting his innervation from, or his supply from, the spinal tract. The spinal tract gets supply from the trigeminal tract. Okay, so trigeminal tract converges into the spinal tract. Spinal tract diverges, so splits into the three different tracts, or into three different nucleuses, excuse me. So, the spinal nucleus, what is the function that's going to be lost here? We're going to have no sensations. What is no sensations? So, specifically, pain, temperature, pressure, and vibration. Okay, so if we're not going to have pain, temperature, pressure, and vibration, where in the body are we going to have it? Are we going to have it down in our arms and in our legs? The loss of sensation? No. We're going to have it specifically in the face. Why the face region? Okay, so now, if I have a lesion, where is this lesion going to be? Specifically in the trigeminal nerve or the trigeminal tract. If the lesion's over around this region, in the trigeminal tract or the spinal tract, I'm going to have a loss of sensation on the left side of my face, the ipsilateral portion of my face. So left side goes with the left, right side goes with the right. There's no contralateral crossings in this region. There's no desiccations. Okay, so where are we? First, for lateral medullary syndrome, we have vertigo, we have deafness, we have Horner syndrome, and now we have ipsilateral loss of sensation of the face. Next up, Nucleus Ambiguous. Fortunately, again, three different regions. However, we'll do it quick. He comes from where? He specifically comes from the medulla of the spinal cord. Not of the spinal cord, excuse me. He comes from the medulla. Okay, from the medulla, he branches out into three different nerves. Cranial nerves 9, 10, and 11. These cranial nerves then branch, so they're branched out around the body, and they converge. They converge into what? They converge into the pharyngeal plexus. Now, these three different cranial nerves supply parasympathetic efferent fibers. What is these parasympathetic efferent fibers for, specifically with the nucleus ambiguous? Okay, they're specifically for the larynx, the soft palate of the uvula, the pharynx, and pharyngeal constrictors. So, these guys, if we have a lesion in the nucleus ambiguous, what are we going to have a loss of? We're going to have something known as, we're going to have a couple things, but the first thing we're going to be known as dysphagia. What is dysphagia? Okay, so the food can travel down. Like we can swallow our food. It's not going down. This is on ipsilateral side. So it's the ipsilateral portion. So if the lesion is on the left nucleus ambiguous, we can't swallow on the left side. Now, dysphonia. We won't be able to speak. Okay, so we have dysphagia. Food can't process down. dysphonia, can't speak. What else? We have dysarthria, we can't articulate. Okay, those are 3 things. Now, what else are we going to have? We're going to have weakness in the soft palate and of the uvula. What is the weakness in the soft palate of the uvula? It assists, or main function is to swallow. So this weakness in the soft palate and the uvula is mainly targeting this dysphagia. Food can't swallow down, known as food can't be swallowed. Correct? Okay. So I know the nucleus ambiguous. We said it branched into 3 different things. Well, now we know it has 3 different losses as well. Dysphagia, dysphonia, and dysarthria. Good. So far we have lateral medullary syndrome, vertigo, neural deafness, Horner syndrome, loss of sensation on the ipsilateral side of the face, and now dysphagia, dysphonia, and dysarthria. Keep going. Spinal meniscus. Okay, a lesion of the spinal meniscus. We've spoken about this pathway. He's used for ascending tract, right? He's an ascending tract. Ascending is for sensory information. Okay, and this sensory information is traveling where? Well, we have 3 different tracts in the spinal meniscus. These 3 different tracts converge together and form the spinal meniscus. What are these tracts? Okay, so we have the lateral spinothalamic tract, which starts where? Starts in the posterior great horn, travels down into the lateral white column, and then ascends up. The next tract we have is the ventral spinothalamic tract. Where does he come from? He still starts in the posterior great horn, crosses contralaterally, and then ascends up. Okay? And now we have the Spinotectospinal Tract, which is fibers from both of those tracts combined, ascending up. These three tracts converge together and form the spinal meniscus. Now, we're not talking about lesions on the anterior or on the posterior great horn. We're talking about lesions after they converge. Okay, so if the lesion occurs after they converge, we're going to be right over here, literally the spinal meniscus. He's used for sensations of pain, temperature, and crude touch. So if we have the lesion there, what's our deficit going to be? We're going to have contralateral loss of pain, temperature, and crude touch on the where? Contralateral side of the body. Why is the contralateral side of the body? Because all of these tracts cross over. They cross over this cross-sectional view of the spinal cord. Okay, so we've finished 6 different things. We have vertigo. We have sensory neural deafness on the opposite side, or the contralateral side. We have Horner syndrome. We have ipsilateral face loss, sensation loss. We have dysphagia, dysphonia, and dysarthria. And now we have contralateral loss of pain, temperature, and crude touch sensations of our body. Last one, inferior cerebellar peduncles. Okay, we know where this guy is. I'm going to draw it real quick one last time. We have spinal cord, medulla, pons, midbrain, the inferior cerebellar peduncles, specifically the medulla region. Medial cerebellar peduncles are in the pons, and the superior cerebellar peduncles are in the midbrain. Now, we're just speaking about the inferior ones. We have a lot of different tracts that travel up through these cerebellar peduncles. Why do we have these different tracts? Because these tracts specifically help us with proprioception, a very important sense. Now, some of the tracts, I'll just mention them quick. We have the cuneo-cerebellar tract, we have the dorsal spinocerebellar tract, and we have a spino-olivary tract. Okay, we remember these guys travel through the posterior great horn, they ascend upwards, and now where do they go? They exit through the inferior cerebellar peduncles to target what? The cerebellum. Okay, the cerebellum is mainly used for proprioception. Now, if we have a lesion in the inferior cerebellar peduncles, so right here in the white matter that takes these tracts and puts it into the cerebellum, we know we're going to have a loss of something to do with proprioception, right? Because the main goal is for proprioception. Now, we're going to have something known as gait instability, also known as ataxia. We're also going to lose sensations from the ipsilateral side of the body. Why ipsilateral? These guys didn't cross over. There was no desiccations. There was no crossover. There's no contralateral crossover. It's only ipsilateral. So if it's on the left side, it stays on the left side. Okay, so ataxia, gait instability, you have problems with walking. What is one last overview? Our lateral medullary syndrome. We have vertigo. We have sensory neural deafness on the opposite side. We have Horner syndrome, right? Horner syndrome is what? No eyelid elevation, no pupil dilation, and no sweating. Okay, now we have no sensations, specifically pain, temperature, vibration on where? The ipsilateral side of our face. So we also have dysphagia, which was that? You can't really swallow our food. Dysphonia, can't speak. Dysarthria, can't articulate. We're going to have contralateral loss of pain, temperature, and crude touch on the where? Contralateral side of the body. Okay, so we're going to lose sensations on the contralateral sides of our body. Lastly, we're going to have gait instability, known as ataxia, on the ipsilateral side of the body. Okay, I know the lateral medullary syndrome was a lot. Just if you mainly know the disorders that come with it, and you could somewhat match it to their tracks, every test question will be easy to answer. So that's basically it, and I hope this helped. Okay, so let's do a couple questions. So a 54-year-old female is admitted to the hospital with complaints of nausea, difficulty swallowing, and altered speech. Okay. Physical evaluation reveals a loss of pain and thermal sensation on the right side of her body. Okay. Sensation, right side of her body. Loss of pain and thermal sensation on the left side of her face. Okay, and her face. And also a loss of a gag reflex. Injury to which of the following areas would lead to these clinical manifestations? Okay, so we see nausea, difficulty swallowing, and altered speech. Okay, so we know nausea is associated with what? Vertigo. We know difficulty swallowing is associated with what? Dysphagia. So we're going to write swallowing. And I'm going to write an X, so difficulty. Okay, altered speech, what is that? Dysphonia. We said this before. We said can't speak, dysphonia. Altered speech. Okay. Now, we know those. Physical evaluation reveals a loss of pain and thermal sensation on the right side of her body. Okay, so pain. Actually, no, before I write that, we're going to do pain and sensation on which side of the body? Right side of her body. What tract gives us sensations to our body about the leg and the arm? Our medial lemniscus pathway. Right? Specifically the dorsal column medial lemniscus pathway. So this is going to be pain, thermal is temp, and sensation on the right side. Okay? It also says we have a loss of pain, loss of pain and thermal sensation on the left side of our face, or her face, sorry. Okay, so what pathway was this? Well, we said it was the spinal nucleus / spinal tract / trigeminal tract. Remember this guy. Okay, and this was what? It was pain, temp, sense, right? On the ipsilateral. Not ipsilateral, on the face. But she said it was on the left side. So it's going to be on the left side. Okay, so now if we draw our structure, and let me draw it a little nicer. This is going to be our medulla. Okay, we spoke about him. Right down the middle to split it in half. The medial regions we had supply from where? Our anterior spinal artery. Our middle of those two arteries come from the vertebral Artery. And then the one that's most lateral, we have is the Pica, posterior, inferior, cerebellar arteries. Good. Now, we said that there is no structures for the medulla that we're going to talk about lesions right now. So I'm going to cross them off. Now, we know that there's some structures where? We know that there's some structures in the anterior and in the Pica. Now, before we go into all of that, I just discussed it all in the video. Let's look at our cases. So, first, if we have nausea, vertigo, difficulty swallowing, and altered speech, right? These three things, where are they coming from? Okay, so nausea, right, and the vertigo, the symptom, is coming from where? The vestibular nucleus. This is in lateral medullary syndrome. So I'm going to draw him in the lateral region on both sides, left and right. So this is our left side, this is our right side. Dysphagia, okay, that's difficulty swallowing, and dysphonia, altered speech. This is coming from a problem in our nucleus ambiguous. Where is this guy located at? He's also in the lateral medullary region. Now, what about medial meniscus with pain, temperature, and sensation? Okay, the medial meniscus is coming from where? He's coming from, I'll draw him in green, he's coming from the anterior cerebellar artery, the medial region. Now, what about the spinal nucleus, spinal tract, and trigeminal tract, which with ipsilateral sensation of the face? Well, he's also coming from the lateral side. Now, what do we know? We know that she has a problem with difficulty swallowing, altered speech, and vertigo. But now, how are we going to separate the different regions? Okay, so let's go to the answer choices. E. Is there a problem with the medial aspect of her midbrain? No, we're not talking about the midbrain. What about a right medial pontine region? Nope, this would be pons, so that's wrong. That means C is wrong too, because that would deal with the pons. We're talking about the medulla. Boom. So how are we going to differentiate between left lateral medullary region or right lateral medullary region? Okay, we're going to go through all our choices and we're going to decide, where are we? Well, first, we know what arteries are we even dealing with. Well, we're dealing with the anterior spinal artery and the Pica artery. Now, if it says lateral, what regions? We're only dealing with Pica. So we know the answer is going to be in the Pica. So we're going to primarily focus on these three structures, but we're not going to forget about the middle guy either. Now, the first thing to determine left or right. Physical evaluation reveals a loss of pain and thermal sensation of the right side of her body. Okay. So we're going to have pain and sensation on the right side of the body. Now, how did we say we got pain and temperature sensation? Well, he came from the medial meniscus. The medial meniscus is located where? Okay, he's in the anterior spinal artery. However, what does he do? He crosses, right? He is a desiccation. So whatever happens on the left side, or the left medial meniscus really takes a right sensory innervation. That means the right medial meniscus takes left sensation. We've spoken about this in another video. So now, if she has pain on the right side of her body, we know it's really coming from where? The left region, so the left side. Okay, so now we know we're dealing with the left side specifically. Now, how do we determine, just to make sure, 100%? We'll still keep going. Loss of pain and thermal sensation on the left side of her face. Well, we said when you lose face sensation, right? It's from the trigeminal nerve, spinal tract, and spinal nuclei. And these tracts worked ipsilaterally. So that means they worked on the same side. So if it happened on the left side, that means she's going to have problems or a loss of sensation on the left side of her face. Therefore, it would be over here. So, what is going to be our answer now? Our answer has to be the left lateral medullary region. Good. Now, I made a follow-up question saying, what artery is affected with this region? Well, you guys got to know this one. Come on now. Here's our structure. What do we have? Right down Broadway, most medial, anterior spinal, lateral to that, vertebral. The most lateral is what? Pica. And what region was damaged? The left lateral medullary region. So this is left medullary syndrome, right? Lateral medullary syndrome is the real term for it, not left. I'm sorry. It could be left or right. It's lateral medullary syndrome. That occurs in the Pica Arteries. So our answer is going to be C, posterior inferior cerebellar artery.